if you had a tool that could help you measure something that was going to happen in the future and something that might give you some predictability of what your musculoskeletal health is going to be as you age. And so that's what we're going to be talking about today. And to introduce myself, my name is Dawn Holy, and I'm the owner of OsteoStrong in Fort Lauderdale on 17th Street. And our passion at OsteoStrong and focus is to help people optimize their bone health, because we understand that the strength of your bones is what drives your whole musculoskeletal system. And so we're starting at the beginning today. Peter Drucker coined the phrase, "What gets measured gets improved." And I can safely say that the people that I know that are listening to this presentation are really, really motivated to improve their bone density. And so we are so lucky today because we have Dr. David Weimer, who is a double board certified radiologist in radiology and nuclear medicine, and he's an emeritus professor at University of Florida, which is one of the top universities in the United States. And he has been involved with DXA technology for 40 years. So there's nobody better than Dr. Weimer to kind of give us an understanding of what DXA measures and what the good parts and the bad parts about DXA are. And then he's also going to be explaining to us some new technology called EchoLight. And we're so lucky in Broward County because that technology is coming in the summer. So I'm so happy. And so thank you very much, Dr. Weimer, for taking the time, and over to you.
It's very nice of you. Right off the bat, nobody's going to have bone mineral density that's better after this talk. I'm just going to tell you what we can do to follow it, all right? Another caveat is that it's a rule of thumb that after 20 minutes, you tend to lose your audience. So at 21 minutes, wake up again. So anyway, all right. So we'll try to, this is going to go a little over 20 minutes, I'm sure. We'll try and cover everything. Not all of it is going to immediately make sense. I've tried to put this in terminology that's readily followable and that in issues that will make a difference to you. So I'm going to share my screen here. So what we're going to be talking about here is bone mineral density measurements. Why do we worry about bone density? As you lose your bone mineral density, your risk of fracture increases, especially in the spine and hip. And particularly important, that's not just going to put you in a cast. Spine fractures are associated with an additional marked increase in mortality risks. So it is important to worry about your bone mineral density. Now, bone turnover in your body is extremely dynamic. Every year, 20% of your skeleton is replaced by remodeling. 20%. You know, at the end of this year, you're going to be only 80% of what you were last year in terms of your bones. Approximately 25% of the dietary calcium that you take in is absorbed. It goes into an exchangeable calcium pool in your blood, and that turns over 20 to 30 times per day. So it's turning over between your bones and your blood pool, 20 to 30 times a day, very dynamic bone turnover. Now, here's generally what happens. Extracellular fluid, you know, that's what your body can use to keep your nerves and your muscles running. You've got it from in and out from the bone. You take in I'm pretty sure that everybody I saw on there is an adult female, not pre-pubertal, but you're taking in, say, 1,000 milligrams per day. You're going to absorb about 26% of that. The rest of it, you're not going to absorb. It just goes out. And of that, it's going to go into bone deposition and bone resorption. So you have a net zero calcium balance unless you're doing something else to increase your bone buildup. Now, prepubertal, you're going to have a positive calcium balance because you're building bone. Now, bone represents the storage site for all of our body calcium. Your body needs the calcium, and it goes like a bank. It goes to the storage site in the bones as it needs it. Now, if you get low calcium levels, all of these things can happen. So the body works very, very hard to maintain an average normal calcium level in the blood, which it does through your pituitary gland, hormones, and what have you. Now, this is an important screen. You can see as we're born, we rapidly build bone mineral density right up to around age 30. And that doesn't matter whether you're a man or a woman. Right around age 30, you're going to reach your peak bone mass. Ideally, you would like that peak bone mass to be as high as you can, because everybody after that is going to start losing bone mineral density. You're going to lose your bone mass. Now, at menopause, there's a stretch there of 5 to 10 years where it really accelerates, and then it slows down again. But it's going to continue to decline. So you want this to be as high as possible so you reach the point where you're osteoporotic at a later stage or never in life. Now, when we look at your T-scores and the T-score graphed against your, in other words, your bone mineral density against your fracture risk, you can see as you decrease your bone mineral density, and each one of these represents a 0.5 loss in T-score, you exponentially increase your fracture risk. So what that means is that a little bit of a change down means a lot. A little bit of a change up means a lot. So you don't want to get too depressed if it's only changing up very slowly, because it is an exponential. So you want it to go up. Now let's look at a couple of pictures of what it actually looks like. The one on the left is a normal hand. The one on the right is somebody who's osteoporotic. Look how washed out it looks. Look at this, is the cortex, this white line right here. This is the cortex, this white line right here. As you lose bone mineral density, it's resorbing that calcium, and you end up with very thin cortex and obviously a much greater chance of fracture. Here's another example. Normal spine on the left, nice normal vertebral bodies, nice normal, almost square shape. And look at this osteoporotic bone here. Very, very washed out. This is osteoporotic to the point you're actually getting superior vertebral body compression fractures related to that. The next step would be for the whole body to collapse down, and then you run into a lot of problems. It can pinch nerves and give you a lot of additional pain and debilitating problems. Now, your underlying bone structure, which is what we're talking about changing and improving or watching, is here. This is an example in the hip, which is one of the areas we measure, which is why I picked this one. This is the cortical bone, which we saw in those ones in the hand again. This is that white part on the hand films that we looked at. That's your cortical bone. Inside the cortical bone is the trabecular bone, this trabecular bone. Now, the trabecular bone is actually very, very important to your fracture risk. It's probably more important than the cortical bone. It also, as you can see, they're very fine bone margins here. They're very fine reticulations that it's easy to lose a significant amount of those. Now you'll notice the orientation of these trabeculations is going almost north-south, and then you've got some others here that are going east-west, and the same is true up here, east-west and north-south. Now, the the way that they're oriented is providing the strength. The ones that go north-south are providing strength for compression. In other words, as you stand up, it's pressing down on these and they keep you from cracking down. Again, the same would be true with these. These other ones here are ones that are providing rotational strength. They also, and I don't really want to get into this, but in terms of the biomechanics of engineering, the strength of the bones is markedly increased when you have these transitional ones here that are going and helping to buttress the ones that are going north-south. So you don't want to lose either of these when you are losing bone. You want to keep them both. These are increasing the strength of the ones that are going north-south with the compression. Now, when we measure bone mineral density, which is one of the things we really wanted to talk about today, historically, we've had a lot of options. You can do CT, which is called quantitative CT. It was one of the early research things, very, very accurate, but you have a higher radiation dose. There was initially, we had single and dual photon absorptiometry, which is why the bone mineral density is often performed in nuclear medicine departments. That was then replaced with what we primarily use now, which is dual energy X-ray absorptiometry called DXA. We'll come back to that in a minute. You can also do ultrasound of the heel. You'll sometimes see that in these portable things out at the mall or in some primary care doctors. They'll do an ultrasound of your heel and look at the bone mineral density of the heel. The speed of the ultrasound through the heel is proportional to the density of the heel. The problem is the reproducibility on that is less than 10%. Good screening tool, but not very good for following the actual day-to-day bony mineralization. Radiographic absorptiometry, which we're not going to get into at all. You can do lateral thoracic and lumbar spine, which we saw that picture a minute ago, where you can actually see the demineralization, but you cannot see early gradations of demineralization. And it's very, very subjective. And one of the latest newcomers to the block is radiofrequency echographic multispectrometry, or REMS, which uses basically ultrasound and radio frequencies to get your bone mineral. And we'll come back to that in a minute. The most common modality, like we said, is DXA. This is a picture of a DXA scan. I'm sure that most everybody here has had one of these already. You're emitting two different energies of radiation, and the one of them is low X-ray, 80 kVp, doesn't mean much to you, but 80, and the other is 140, and bone and soft tissues absorb those at a different rate, and then you can measure how much of each of those is coming through and mathematically calculate the bone mineral density of where the X-rays went through. You then compare the value that you get out of that mathematically calculated value, and you compare it against population normals. Now, we'll come back to more of that in a minute. And the way it works, you've got the X-ray tube. Here's a patient, right? X-ray tube below the patient, laying on the table. You've got the scintillation counter. That's the receiver that's receiving the X-rays. And the X-rays go through the patient up to the scintillation counter, and then everything is calculated from there. The whole study, depending on how much you're doing and how compliant the patient is, can be 2 to 5 minutes per site that you're going to look at. Very, very quick from that standpoint. And it's got a plus or minus 1% accuracy. What that means is if I do you right now and 10 minutes later I do you again, I should get virtually the identical result. So that's very, very important. That's like we said, with ultrasound, that's not going to be true, but it's very, very accurate with DXA. Now, it is X-ray, so obviously a concern is radiation exposure. The radiation dose, however, is extremely low. It is 0.01 millisieverts. Now, that values don't mean much to you, but put it in perspective, it's less than 1 year of background radiation dose. It's less than the amount that you get flying from here across country in the plane, because you're up in the cosmic x-rays. It's significantly less than a year's background radiation in Mile High, Denver, where they have higher background radiation. The dose is so low that you don't have to have any special shielding of the room. You can put it in a standard room anywhere, in an office, in the hospital, in a clinic, and you don't have to have a dedicated technologist, except in some states, and Florida is one of those states, where a technologist has to be X-ray Association of Radiology Technologists certified in order to operate the equipment. Most states, that's not true. You do it, you pick a bone that you want to look at, the spine or the hip or the forearm, and you take images. The most common sites that we do are the lumbar spine and the hip. Some of you may or may not ever have had a forearm. That is a very limited need use. And then you can do full body DXA, mainly in pediatric patients. You can also do a whole body DXA for body composition, your body fat to muscle ratios. You can do the calcaneus, the heel, but it's rarely done. That is the area that's used for the quantitative ultrasound, as we mentioned. Lumbar spine, how it's done. I mean, you guys have done this. It's not, I'm not telling you anything here. This is a typical classic way that you position the patient. You put their knees up, it straightens the spine out. You can do a lateral. The lateral is primarily helpful for looking for compression fractures. The imaging will be from T12 to L5, and then you're going to take regions of interest. These are your regions of interest. This is what a typical normal display will look like. Now, I don't know if any of you actually have had an opportunity to see the printout and all of the images that you got, but they should look like this. So this is the first lumbar vertebra all the way down to the fourth. We skip L5 because oftentimes it's oriented a little bit differently and there's a lot of degenerative change there. After you've got it positioned correctly, the computer takes over. It's sort of like the original AI. It automatically traces out each of the outlines of the vertebra and separates them 1, 2, 3, and 4. Now, when you're doing a lumbar spine, the World Health Organization initially came out with recommendations not to rely on the lumbar spine after age 60 because you get a lot of degenerative changes. You get bone spurs, osteophytes is what they're called, coming off. You get a lot of sclerosis of the bones because of the degenerative changes. And overlying the spine, directly down here, is the aorta, directly positioned over this. After the age of 60, we see a lot of calcification in the aortas. And that obviously is going to be added in to the apparent calcification in the vertebral body, giving you a spuriously elevated result. Calcium's in the aorta, it's not in the spine. We want the leg straight, and you turn the hip, slight internal rotation, and that gets the lesser trochanter out of the field and gives you a uniform way of measuring from one time to the next. You know you've got the same positioning. Now, you can do regions of interest, which you typically do in doing the whole hip, femoral neck, and trochanter. And this area here is called Ward's Triangle. Ward's Triangle is one of the least populated areas with bone trabeculation. So it's easy to see on plain film x-rays when that starts to get less and less. So that's an area you would look at on a plain film. Oh, I will mention, remember we talked about the positioning and the orientation of the trabeculations. So tensile, this is the tensile, secondary tensile. That's a primary tensile group. That's going to keep it from breaking side to side. These are your compressive groups, and compressive groups coming down here, compressive groups here, which are the ones that are keep it from crunching down. So, and those are where the trabeculations are. Now, when it's done correctly, this is what the hip will look like. Notice we've got a square box, which needs to be looked at every time. You can't just put the patient on and expect the computer to do it 100% correct every time. It doesn't. So you have to have someone who looks at it and judges it to make sure everything's correct. The computer is going to try to outline what it thinks is the correct cortex. And we'll see in a minute, it doesn't always get it right. You put these regions of interest, which have to be over the femoral neck and centered over the femoral neck, and they need to be correctly positioned away from the trochanter and away from the pelvis, because you don't want to include those in the femoral neck measurements. All of these things have to be evaluated when you're looking at your DXA images. Now, we did mention that you can do the forearm. Forearm is typically only done in patients where you're following them up for hyperparathyroidism, whether it's primary or secondary, either because you've got a pituitary tumor or you've got renal disease giving you hyperparathyroidism, because the region of interest we're most interested in is the distal 1/3 of the radius, and that's here. And you'll see in this area right here, the cortex is the predominant portion that we're measuring. And cortex is the area that is primarily affected with hyperparathyroidism. So we can very sensitively measure how we're treating the hyperparathyroidism and how the hyperparathyroidism is affecting you by measuring the bony mineralization in this region. It's not as effective for evaluating for bone fracture risk, because again, we're looking at cortical bone, not the trabecular bone. Whole body DXA, again, typically in pediatric patients who have bone problems, congenital bone problems, or what have you, osteogenesis imperfecta, for example, where you do the whole body to measure it. Now, you have to have dedicated software in order to do this because kids are different. Their bony mineralization, the way that they mineralize is different. They have growth plates that make it different. So you really have to have a dedicated software. In adults, we do this one for the body fat or fat to lean body mass ratios. In the standard DXA, you get images, you get bone mineral density, sorry, a typo, numbers, and then you get a statistical analysis of what those numbers mean. Now, the interpretation, when you see the report that is coming out, it should give the indication which affects the fracture risk, an evaluation of the images themselves. Otherwise, it's a good study, it's not a good study. What else can you see on the pictures? Can you see fractures, other degenerative stuff? And then finally, the statistical analysis. Now, this is a typical report, awful busy. It's just to show you that there's a lot of information that you can get off of the DXA scan. Usually what you end up seeing most of the time, if you get something at all, will be a modified version of that with only the limited amount of information that they felt you need. Here's a typical picture that is generated by the computers. Now, notice here we've got L1, 2, 3, and 4. Those are correctly marked. This is a graphical representation with the bone mineral density for the L1 to L4 marked right here. It's in green. It means it's good. It's normal. And here it is in the change from baseline. It's 0. No, it's good. Everything's good. The problem is when we go back and analyze this, look here at the L4, L5 level. Look how white that is. That's degenerative change in the spine. That is spuriously elevating that. So let's go back and look at the individual levels. L1 has a t-score of -1.8, L2 -1.5, L3 -1.4, L4 1.7. It's not right. It's because there's too much sclerosis, so you'd have to throw that one out. In other words, when you look at this, you would not report that this patient has normal bone mineral density, in spite of the fact that the L1 to L4 average is in a normal range. The patient actually has osteopenia, and that's the way it should be reported. Here's a typical output for the hip images. Again, the pictures which you look at to make sure everything's done correctly. Everything looks good here. We look at the femoral neck, gives you a t-score. We're going to come back to what the t-scores and z-scores mean in a minute. A t-score of -1.3, that's osteopenia. And there's your report. Again, we want to make sure that the positioning is correct. make sure that all the edges have been detected correctly, regions of interest are marked correctly, and then any other unexpected abnormalities. Increased density, like from a bone tumor, particularly prostate cancer, metastatic breast cancer, can give you sclerotic changes. Melanomas can give you sclerotic changes. Myeloma can give you areas that there's no bone at all because the tumor's replacing it, and that'll give you spurious numbers. Are there fractures that are in the site? Maybe the patient didn't know they had a fracture. Are there osteophytes that are artificially elevating the bone mineral density? Here's one inappropriate technique. So this is not going to be reproducible from one year to the next because it's been improperly positioned. We've got this lesser trochanter, this bump right here should not be there. Go back, see, this is the way it should look. It's not there. There it is. It's improperly positioned. And the person reading this should make a statement in the report that that's what's happened. Now, here's a case where we're looking at it. Look at what the computer did. It took the area of interest all the way up and around the pelvis. Obviously wrong. You cannot use these values. It has to be redone. So what do the numbers mean? Here's a typical graphical representation. If you get a picture like this, if your little box is into green, that's great. If it's into yellow, you're osteopenic. If it's into red, you're osteoporotic. That's just kind of a gross overview of where you are. And when you have multiple from year to year, you'll have multiple little X's along in here showing how you're doing over time. Now, the definition of osteoporosis is decrease in quantity of otherwise normal trabecular bone. After age 30 to 35, we expect a decrease on average. Remember, we saw that it's faster through menopause, but on average of about 2% decline per year. That's going to happen. Not a whole lot you can do about it. Normally, you can work at it with various things with your diet, various types of exercise and what have you, to try to mitigate that as much as you can. But in today's society, with the average person being as couch-ridden as they are watching TV or on their cell phones or whatever, the average bone mineral decline is 2%. I expect we may see that increase when they do a recalculation in another decade or so because of the changes in the way people are. This is based on data from 20 and 30 years ago when people were perhaps a little bit more active than they are now. Now, the World Health Organization defined osteoporosis as a decreased bone mineralization of greater than 2.5 standard deviations, in other words, negative 2.5, below normal healthy bones. Now, we use a standard deviation because various pieces of equipment have different values of the actual bone mineral density because of the way they calculate it, but their standard deviations should be very close to the same from one year to the next. But you can't look at the actual bony mineralization density because the different machines are different. That means that if you're going to get a scan and then you get a scan at another place, you may or may not be able to compare the values of what's happening. It may be higher, it may be lower, and nothing's changed with you. So you have to use the same equipment from time to time. Now, we do get T-scores and Z-scores. Somebody asked me the other day, what does T mean in a T-score? T is a typical statistical representation. This means test. So it's a T-score. It's a test score. So the T-score and the T-score and Z-score are based on standard deviations from the mean. Just helps with interpretation. The Z-score is the standard deviation from the mean for that patient's age. So you may be the exact right on dead zero Z-score, the same as everybody else your age, and all of you are a little osteoporotic just because we saw that decline 2% per year. Your Z-score might be less than the other people of your age, in which case maybe there's something else going on. Maybe it's because you're on steroids or some other thing. When we see the Z-score that's out of kilter for your age, we got to look for other reasons for your declining bony mineralization. Now, the T-score is a standard deviation from a normal, healthy, young adult, white, female, 20 to 30 years old. Now, I suspect that if we did a recounting of the mean in today's population base, it might be different. This is based on stuff from, again, a couple of decades ago, but it's usable because once you change away from what that value is, your rate of fracture risk still goes up regardless of the norm that we originally used. The T-score is what the World Health Organization definition uses to determine whether you're osteoporotic. Now, -1, in other words, 1 standard deviation below up to 2.5 standard deviations below is osteopenia. It's low, but it's osteopenia. It needs to be higher. Less than 2.5 is osteoporosis. So that's how we define osteoporosis. Now, each manufacturer has their own normal database of patients that they use for the calculation, and they vary from company to company. Again, that means that you can't directly compare bone mineral density between different machines. Now, we do additional analysis to determine your fracture risk. A T-score in and of itself, so you're osteoporotic. So what? Does that mean I'm going to have a fracture or not? So we do what's called the FRAX determination. Now, this was developed in England at Sheffield University, along in conjunction with the World Health Organization, and it determines the 10-year risk of hip fracture and a 10-year risk of major osteoporotic fracture. It takes into account multiple variables in order to calculate that, and it is used by the National Osteoporosis Foundation for determining treatment guidelines. So depending on what your 10-year hip fracture and osteoporotic fracture risk is, will determine some of the treatments that are going to be recommended for you. Now, the patients who are too young, in other words, under age 50, or have taken any kind of medication for osteoporosis treatment, or already have had fractures, are not included in the fracture risk assessment because you're already considered at high risk. Now, here are the parameters that it looks at. Country is interesting. For example, Japan, the average bony mineralization compared to the United States is a high incidence of osteopenia and osteoporosis, but their actual fracture risk over time is less. Now, I have no idea really why that is. I suspect it's because their obesity is only around 12%, and our obesity is over 36%. So maybe it's because we've got a lot of obese people that their bones just can't handle it and they fracture. So the country matters, the age matters, the sex, weight, height, previous fracture, hip fracture, smoking, steroid treatments, rheumatoid arthritis. Usually that means that you probably had steroid treatments, other diseases that are associated with osteoporosis, alcohol intake of more than 3 standard drinks per day, and bone mineral density of the femoral neck. So all of these go into the FRAX parameters to determine your fracture risk. Now, other bone turnover measures. So when the bone remodeling is quiescent, you're getting bone formation. Bone formation gives you all of these things into your blood, and these are little fragments of things that get out into the blood that we can actually take a blood sample and look at, and we can say, wow, there's an increase in bone formation. Now, when you've activated bone remodeling and you're getting bone resorption for whatever reason, you come down and you activate these, and you're getting these spin-off particles into the blood for bone resorption markers. So we have bone formation markers and resorption markers in the blood that we can look at. Now, they're not going to tell you if you're osteopenic or osteoporotic or normal. They're just going to tell you that those are elevated. The International Osteoporosis Foundation has picked the serum CTX, that's this one, and the serum P1P, which is this one, as the 2 primary reference markers for bone resorption and formation. So if you want to assess your monitoring of therapy and therefore fracture risk in clinical settings, those are the things that you would want to look for. You'd want to see one going up and the other going down, or at least both of them staying the same. But just so you know, there are other things that you can look at in your blood. Current recommendation from the Preventive Task Force is that 65 years or older should be screened. Now it's a screening, to do a baseline screening at age 65. Now, if you've got other reasons for it, that doesn't mean you won't get a scan. There are other reasons for getting scanned, but just getting screened, they're saying at age 65. And then you would get follow-up scans after that, no more frequently than once every 2 years. And the reason for that is that, again, we said the accuracy is around 1 to 2%. If it's 1%, that means from year to year, you can change 1 to 2%. And it's still within the statistical variation. You have to go out 2 years to get 2 standard deviations statistically to be significant. So you've got to wait 2 years. So that's how Medicare came up with their idea that you can only reimburse once every 2 years. In younger patients, well, in the older patients over 50, both men and women, we use T-scores for determining it. In under 50, we primarily look at Z-scores because you want to compare against your cohort of patients that are the same age. So in that case, you're using a negative 2.0 as your cutoff point. And if you're less than 2 standard deviations below other people of your age and you're under the age of 50, then you're too low. Image on the DXA machines, and you can actually assess for vertebral compression fracture. You can see here, we've got a compression fracture. We've already got a compression fracture. This patient is so washed out that they've already got a compression fracture. These can be very painful. They can be debilitating. They can give you the dowager's hump, the hunched over look that you get, depending on where they are and how severe they are. Lateral imaging is indicated in women over the age of 70 and men over the age of 80 who have a height loss of greater than 4 centimeters from 1 year to the next, or a reported history of prior vertebral fracture. Also, patients who've had long-term steroid therapy. You want to get this because you want to look and see if they've already got a fracture that you need to watch and follow. Now, we mentioned the trabeculations as being important, and the new tools that are out there have gone an iteration above just looking at bone mineral density. We're actually getting a trabecular bone score looking at the bone integrity. Now, here's a normal trabecular bone in the vertebral body, and here's one that's abnormal. And we've got a trabecular bone score of 1, nearly 1.4, and down here at 1.1. So it's telling us an additional beyond the bone mineral density of what's going on in that patient. So we're going to see more and more of that as a useful tool in monitoring treatments and therapies. Again, in hyperparathyroidism, you look at the distal 1/3 of the forearm because that's where the cortical bone is. You can do body fat composition. You're going to do a whole body DXA. This is, it's very accurate, but it's not reimbursed by insurance. Nobody's come up with a reason that you really need to do it. Some sports enthusiasts are doing it in particular when they're training or getting into shape. They're looking to see what's going on. Now, there is potentially some use that we might see in the upcoming decade because as you get older, there's a thing called sarcopenia. That means you start losing muscle mass. We all know that. Older people get weaker. They can't move around as well, can't get up and down as well. It's because they're getting sarcopenia. Sarcopenia means muscle loss. So you could use a whole body bone or whole body fat and muscle composition to monitor what's happening with their muscle mass also. That has some relation and indication and relationship to cardiovascular disease as well, but that's a work in progress. This is just an image of what a total body composition analysis will look like. You're taking the whole body picture. There's what the original picture looks like, and then it analyzes it for fat to muscle ratios. Now, the latest newcomer to the field is the radiofrequency evaluation. Now, this uses radio frequency and ultrasound waves to determine the bone mineral density without any ionizing radiation. It was developed and currently sold by a company out of Italy. It received FDA clearance in 2018. So that's almost 7 years ago now, but it just in 2024 got the Medicare approval and a CPT code. So that's why to date, because it didn't even have a CPT code, it wasn't being adopted in the United States. But now in 2024, here we are. People will start using this. I think we're going to start seeing more and more of this around the country because, again, it's got no ionizing radiation. This is the unit. You know, it's very portable. You can go to the patient's bedside. You go to the patient's home. You could do it in your office. You can do it anywhere you want. You just take the machine with you and do the analysis. The accuracy is virtually identical to that from DXA. So you're not losing anything except for the radiation. The radiation in DXA, personally, I don't worry about it. It's not worth worrying about. But REMS has no radiation. So there is a difference there. The other key thing here, and we'll have to see how this pans out over time, but the data so far suggests that it's not affected by the osteophytes, which are those bone spurs, and spinal hardware, which make DXA non-diagnostic. So you can't even do spines in some patients, you know, like that L4 vertebral body we looked at is going to be abnormal on a DXA scan, but we can probably get around that with the REMS. We'll see if that really pans out over time. At the very least, it's no worse than DXA in not being able to evaluate those. The results that you get, the printout, is almost exactly the same as with DXA. You get the bone mineral density printout, you get T-scores, and you get Z-scores. Now, you don't do a trabecular bone score, you're doing a fragility score, which is taking into account the trabeculations in the bone. And it's been validated to be accurate and reliable at predicting the bone strength. In other words, the fragility. And that'll give you your 5-year fracture risk. Now, you can have a low bone mineral density and a good fragility score, or vice versa. You know, so it really does behoove you to get the analysis of both of them so you know where you stand in terms of your possibility of fracture. Here's a printout. Again, very, very similar to what we saw with the other. You get your graph of green, yellow, red, the vertebral bodies, the numbers associated with that, Z-scores, T-scores. The same is true with the hip. Again, the printout, individual pages that you would get with the way the printout would look. And you can do whole body bone and fat analysis with this also. And it's just another picture of that. You can do everything that you can do with the DXA. Anybody that wants more information on clinical densitometry, the ISCD has a full review of those, so you can Google that. The other thing is if you want treatment guidelines and what have you, National Osteoporosis Foundation, that's NOF, has a very robust website for looking at that kind of stuff. So that's all I wanted to go over. Everything that everybody cared about. Is everybody still awake?
I know I am. So
Hey,
I'm
is
going
this-
to open it up to questions. Thank you very much, Dr. Weimer. I have a few questions of my own, but I'm going to start with some of the participants. Does anybody have a question?
Yeah, I do. So what? So is the Echo Light now it's gonna be paid for by Medicare because they got that CPT code?
At the present time, Medicare has not recognized it. They've just given it a code. That's what they usually do first for a year or so. They'll put it out there. They've done that with everything I've seen in radiology. Even the things that are obvious that they should be paying for, they won't pay for it for a year or two. You get what's called a separate Z code or a T code or an N code that you attach to it. in the coding, but at the present, and that what they're doing is basically gathering data to see how much it's being used and whether or not people are using it enough for them to worry about making it a payable thing. They don't just give payable resources to everybody that comes by asking for one. They want a couple of years worth of data to show that people are doing it, it's out there, it's being used, and then they'll start reimbursing for it. So no, at the present time, you have to give it a special code, and we're just waiting for Medicare. Hopefully, with the CPT code that came out this year and the FDA approval, that'll be forthcoming within the next year to 18 months. But who knows with the federal government.
On the CTX and P1NP, about the bone turnover markers, is there a reference page on how to interpret them?
I'm sorry, I didn't catch all of that.
On those bone turnover markers, CTX and P1NP that you mentioned,
Yeah.
Is there a place where you can get some information how to interpret them? Because a lot of times you can get it, but how do you actually interpret that? It's a really interesting question.
Yeah, I'm going to have to refer that over to the laboratory and pathology people to give you that. You can get the normal ranges and what have you, and exactly what does it mean and what have you in terms of following it. You're outside of my bailiwick.
So, Richard, I have a little bit of information about that. And there's a book called Better Bones, and I can give you that offline. But what they suggest is if you take the averages, and if you implement something, let's say you get a baseline and your P1NP is a certain level and your CTX is another level, and then you implement a strategy, and then you see an increase in your P1NP, which is bone the bone building, and then a decline in your CTX, which is the breakdown. Then you have more of a feeling that what you're doing is impacting bone turnover. And then I've also seen some suggestions that if your P1NP is in the top third, and there's some levels for CTX, but there are some guidelines that you can find that talk about that.
Okay, we'll discuss on LinkedIn.
Perfect.
Thank you. That's all for me. Thanks.
I had a couple of questions. One thing that kind of jumped out at me is that you said that right now T-scores are being determined with averages from 20 to 30 years ago, and that's going to be might be changing and being updated, which personally, I feel like people are more sedentary and their health is declining. So are we really served by moving those averages, comparing us to a less healthy population? Like, really, it's like, okay, if my bone mineral density is X, how likely am I to fracture? Who cares how I compare to the rest of America?
I'll turn you into a bunch of jellyfish, and therefore you're okay. Your bone mineral is good. You're just like all the other jellyfish. Yeah, I don't know where that's going to go with that, or whether or not they decide they're going to stay with what is considered strong, bone averages. We'll have to see where it goes.
Well, another question I had was, you said after 60, the spine is not reliable because of calcification of heart.
May not be reliable.
May not be, which is
Not
ironic. You're not
Yeah.
even checking till 65, right? So,
Right. Well, that's why you put more weight on the hip.
mm,
And that's why something that is not affected by bone spurs and bony sclerosis might be a better way of following that. But not everybody has bad spines, just most.
yeah. Well, then you also made a comment about how obesity impacting fracture risk. Can you tell me a little bit more about that?
That's interesting. There's two different sides to that. One is that if you look statistically at it, people who are obese tend to have a higher bone mineral density on average for the same age than people who are not obese, probably because of the weight bearing that they've
Will this
got.
new scan,
It's like always carrying around weights, and you're increasing the stress on the bone, so therefore you keep a good bone. The problem is that you need even more bone when you get obese, so therefore your fracture risk does go up, even though your bones might be a little bit more, you might be in the osteopenic range, but if you do a frax number, it's going to show you've got a high fracture risk in the next 10 years.
Then I had one more question too, because I've also seen a big difference in some people's DXA scans where they might have a really low bone mineral density in their spine and not in their hip, but they might have, or vice versa. And I know that there are some companies out there that are only measuring, like, I think it's the dominant hip. They might only measure one hip and the spine, not both hips and the spine. And so I was a little bit confused about that. Do you know much about that?
Yeah, right. It certainly could miss some people if you're only doing one area. Now, if the patient has bilateral hip prostheses, you're out of luck. You're going to have to use the spine or whatever else information you can get. We see a lot of times where the spine and the hips are disparate. One will be osteopenic, maybe even almost normal, and the other will be osteoporotic. The National Osteoporosis Foundation made a statement. It says you will use the one worst area to determine whether the patient is osteoporotic or osteopenic or normal. So you don't report the spine is normal, but the hips are abnormal. You report is abnormal. You pick the one worst area defines whether or not the patient is osteoporotic or not.
All right. Any other questions? I think this has been amazing. Diana, do you have a question? Let me take you off mute. Or maybe you can unmute yourself. We can't hear you. Can you unmute? Diana, we can't hear you.
okay, sorry.
There we go.
Okay, so, I just lost my train of thought, I'm sorry. Okay, so on the report that you're, what's the name of the new thing that's out, so I can refer to it? Rex, what's yours?
REMS, just call it REMS.
REMS, okay. So on the REMS report, because I have one hip that's worse than the other, and then, so I have osteoporosis in the spine and in the hips. Will your report be able to show, both the hips and not base? I mean, what's the difference between your report and their report and how it's going to benefit us? And this could be a two-part question, kind of a three-part. Let me just throw them all out because you might be able to answer. The other thing is I do have osteophytes in my hip area. I didn't know that can affect it. I'm 59, I'll be 60 in a month. Will this new scan be able to be more accurate? And then another question regarding that scan. Will it be a better determination regarding, because I have aortic calcification as well. So will your scan be able to be, better determination of my overall
fracture, right?
Yeah.
Huh?
Yeah.
Yeah.
Yes.
Yeah, they have me at a very high fracture risk.
Yeah. When you do ultrasound and radio frequency, you set the depth that you want to look at. So in terms of the spine, we would look around that. It would not be an issue. Now with the hips, do you do one hip? Do you do both hips? Certainly in a case where there's a history like yours, where you might be interested that the two sides are different, which may be because you had more degenerative change on one side, you were favoring one side over the other, so that your bone mineralization is going to be asymmetrical between the two sides because you're weight bearing. You certainly can modify what you're looking at. You can do both hips. DXA typically does not do both hips, but you can also do DXA at both hips or either one. We typically do the left with either DXA or anything else, just because that's a standard that everybody developed. But we could have just picked the right hip if we'd wanted to. There are a number of times where a patient will have a total left hip and we'll just do the right hip. So in a case like yours where there was some concern, maybe you would just go ahead and you'd get both hips just to make sure you can follow both of them. The timing of the scan, and since there's no radiation, it's negligible. You just go ahead and get what you need to get the answer.
And then the osteophytes site or fight, is it osteocytes or fight? So will yours, did you already answer that? Because I was trying to follow you.
Yeah, yes. When you're measuring, you measure again around and adjacent to the osteophytes, not including the osteophytes, which you don't have a choice of with DXA.
Okay.
You do with the other.
Great.
So, Dr. Weimer, if I'm correctly understanding the difference and the main benefit of REMS is that REMS is actually measuring that bone matrix, which is the real strength indicator versus DXA, which is measuring the outside cortical bone. Is that correct? Am I correct in that?
Pretty much. I don't want to disenfranchise DXA because they have come out just in the past, I think it's 2 years, with an additional software analysis that it can look at trabecular bone also and gives a trabecular bone score. There's a company that came out and has a software add-on to the DXA machines where you can get a trabecular bone score and then you've got the same data. So yes, but you have to have that extra additional add-on, and there's very few DXA machines out there that have that yet. But then it would be the same.
I'm sorry, is that how my doctor was able to say, you have very severe osteoporosis, you're at a high risk fracture, however, your bones are very strong? Is that how she was able to tell that? Because I was
Correct.
like, how does she know my bones are strong?
Yeah, we want to look at that trabeculations because as the trabeculations are resorbed, that really increases your fracture risk much faster than the cortical bone does. And particularly, remember we saw the different crossing of the trabeculations, right? So I didn't want to get into this, but from a biomechanical standpoint, the strength of a strut is proportional to the square of its length. Okay, so if I have a trabeculation going north-south that's providing your compression strength, and I've got a bunch of ones going east-west, those are the ones that are dividing that strut into pieces. So let's say I've got one going just right across the center. Okay, if I didn't have that at all, let's say it would be a strength of 1. I put 1 across it. I've decreased the length of the strut by a half. I've increased the strength by 4. Okay, so the problem is that as you get demineralized, this is way beyond where we should be, right? But as you get demineralized, the problem is that a lot of the demineralization occurs in those cross struts first, because your weight bearing is helping to protect the ones that are going north-south, but there's nothing to protect those ones going east-west. As you lose those, you lose strength exponentially as the square of the length. So it is very, very important to be looking at that trabeculation. Too much.
And yours is standard with that.
Yes.
Good. Okay.
So I just wanted to mention Dr. Patel, who is listening, put a question in the chat about whether there's going to be an opportunity to get a REMS scan in South Florida. And, you know, our understanding is that a machine is being purchased and, you know, our plan is to offer in conjunction with them scans at OsteoStrong.
Oh, awesome. Thanks, Dawn.
That's what I thought.
Yes. Any other questions?
This was very interesting.
Yeah, very helpful, very informative. Really appreciate it.
No, glad. I'll give you one last piece. The length of the appendix in a koala bear is 3 feet long. That's all you're going to remember out of this. And you can take that back to your kids and grandkids. And it's that long in order to digest the eucalyptus leaves.
Thank you, David. You're awesome. Really appreciate
Thank you. Thanks, everybody. Have a great day.
Thanks, Dawn.
Thank you.